We want to present to you the topic of complex regional pain syndrome. That's a new terminology developed in the last 15, 16 years, previously and still known as reflex sympathetic dystrophy. I'd like to just go over some historical perspectives of this. I always find it interesting to know where we've been and how we got to where we are as part of understanding of what we do, why we do what we do, etc. So the first, complex renal pain syndrome or reflex sympathetic dystrophy was probably recognized many decades, centuries ago, but the first medical description of it in the medical literature was by a surgeon named Denmark. It was in one of the European wars, and he described a soldier who was injured and developed severe burning of his upper extremity, and described the symptoms and the signs and the presentation as we would see it today. It wasn't until the mid-1860s, actually during the Civil War, that the concept of causalgia or burning pain was described. And this was a result of the injuries in the Civil War. High velocity musket ball injuries near nerves provoked the development of this causalgic syndrome. And Mitchell, Morehouse, and Keene wrote a treatise which, again, describes clinically in detail the findings and observations of patients who were injured in the battlefield and developed this causalgic syndrome. Causalgia comes from the Greek, meaning burning pain, and that's where the term causalgia originated from, was from this term improvised by Mitchell, Morehouse, and Keene. In 1864, Paget described autonomic changes in patients with causalgia, the skin and the vasomotor changes. So that was the first description of, outside of these descriptions, he described this in detail and primarily focused on the skin and vasomotor changes associated with the syndrome. Then, towards the late 1800s, early 1900s, X-rays were developed, and X-rays were being used to look at the bone structure, and Sudeck. Sudeck described the patchy bone demineralization that was associated with causalgic pain, and that's where the term Sudeck's atrophy comes from. Sudeck described the demineralization of bone in these patients. And so the mainstay of treatment in the Civil War and post-Civil War era was morphine. And morphine led to the development of tolerance and physical dependence. And there was a term that came out of the treatment of the soldiers for their causalgia, and it was called soldier's syndrome. And soldier's syndrome was something that was referred to in terms related to the physical dependence of soldiers because of morphine. And if they didn't get their morphine, they'd go through withdrawal. And they would ask for and beg for another dose of morphine, not just to treat their pain, but to minimize their withdrawal effects. So there was very little that was available, and what was available wasn't all that great. In 1915 and following, Leriche was a French surgeon, vascular surgeon, and Leriche described sympathectomies, surgical periarterial sympathectomies for the treatment of causalgic pain. And he also described, procaine was developed in the early 1900s. The first, cocaine was the first local anesthetic, and procaine was a synthetic development of an injectable form of anesthetic agent. And he described procaine infiltration of sympathetic ganglia as a treatment. Now, this was done openly, surgically. It wasn't through a needle. It wasn't like we do now using fluoroscopy. He would do surgical exploration. He would inject with procaine in the sympathetic nerves and the sympathetic ganglia, and he would remove, as part of the treatment, the sympathetic nerves and the sympathetic ganglia. He also described dorsal sympathetic ganglionectomy from the lumbar vertebral vertebra as a treatment. Then White described, in 1930, White described the first nerve block done percutaneously of sympathetic nerves. And so he said, well, you know, maybe we can figure out who, because obviously not everyone who had the surgery responded to surgical treatment. There were patients who had the surgery, some responded, some didn't. So White described a diagnostic blocking technique where you put the needle near the lumbar ganglion and you inject local anesthetic and you see if they get relief as a prognostication of whether they would respond to a sympathectomy. So this was a first time that a nerve block was used for diagnostic purposes to the sympathetic nerves directly to determine if it would be effective and if surgery would therefore likely be effective. Okay, so as time went on, in 1947, there still wasn't a name for this except for causalgia. There were a lot of different names given to it. Nothing really fit, and nothing really caught on until 1947. Evans reviewed the literature, and Evans was the one who coined the phrase reflex sympathetic dystrophy. So from 1947, the term reflex sympathetic dystrophy came to dominate the description of this clinical manifestation. And he based this on what was believed to be occurring physiologically, that it was thought to be a reflex response involving the sympathetic nerves because of what was described by Lariche and White, and that the extremity involved typically became dystrophic. So he put together reflex sympathetic dystrophy as a term for this condition, and it's stuck with us ever since. In terms of treatment, not much outside of sympathetic nerve blocks and sympathectomies were performed. Opiate analgesia was still used, but reluctantly because of this soldier syndrome and physical dependence, and people were concerned about that. And so in 67 and 74, these individuals used IV regional guanethidine. And the idea is that guanethidine blocks the reuptake of catecholamines after their release. So guanethidine is an antihypertensive agent, and when it's administered, the catecholamines that are released cannot be taken up, so they get depleted. And because this was thought to have a sympathetic component, if you block the sympathetics, you block chemically the release of adrenergic substances from the sympathetic nerves, you should get relief. It was used and it was tried. It has had variable success. It is not considered a standard of treatment because it has not been shown conclusively in a couple of blinded and open studies to be effective. Also, you have to remember IV regional guanethidine is done through a Beer technique. Beer is a surgeon who used a tourniquet on an extremity, put an IV needle in. He'd put a tourniquet on the extremity, either upper or lower, and he would, before he put the tourniquet on, he would exsanguinate the extremity with an esch mark or rubber elastic bandage to get to drain the blood, and then put the tourniquet up. So now you have an empty extremity of blood, and then through the needle that had been placed, he would inject procaine. He'd get anesthesia of the extremity, and he'd do a surgery. So that was the Beer technique, and these individuals used the Beer technique to deliver guanethidine intravenously with a tourniquet on. Now, if those of you have seen complex regional pain syndrome patients, they're very painful, and some of them won't let you touch their arm, and some scream unless you go to the OR and give them anesthesia to do it. Some will scream as you wrap the arm and put a needle in or do whatever. So it's not an easy technique to do. It may require heavy sedation or general anesthesia. It's cumbersome, and the results really didn't pan out. Another concept that developed in 1985 is that a researcher, Roberts, introduced the concept of sympathetically maintained pain. What he said, he reviewed the literature and the information, and what he said was that there are some patients who respond to sympathetic blocks and some who do not. And therefore, those who respond to sympathetic blocks must have sympathetically maintained pain. And those who don't, he said, have sympathetically independent pain. So that's where that concept of sympathetically maintained and sympathetically independent pain arose. So there continued to be confusion about this. People looking at this question whether the sympathetics were really involved or how much they were involved, because some patients responded to sympathetic blocks, others didn't. Was it really a reflex response, and so forth and so on. So in 1994, the International Association for the Study of Pain conferred actually a series of meetings to discuss reflex sympathetic dystrophy, its terminology, and what was known about it, and appropriate treatment. And they decided to introduce the terminology complex regional pain syndrome, and that was to replace reflex sympathetic dystrophy and causalgia, both of them. However, these terms, reflex sympathetic dystrophy and causalgia, had been entrenched for about 50 to 100 years. So it wasn't going to be easy to replace it. Now, historical perspectives on the theory of sympathetic dystrophy. Livingston was a neuroscience investigator, and he proposed that there was what he called a vicious circle of reflexes, hence the term reflex in the term reflex sympathetic dystrophy. Dupay, another researcher, claimed to have found in animal models synapses, artificial synapses between injured nerves and sympathetic nerves, and it was thought that produced the sympathetic discharge produced the pain generation through the somatic nerve through these artificial synapses. 65, Melzack and Wall's gate control theory, and 78, Melzack and Lozier's central biasing mechanism proposed that the central neuromodulating process of the individual had gone awry, and that painful stimuli were not being inhibited as you would expect normally, and so the pain processes would go through the spinal cord to the higher central nervous system, and there was a biasing mechanism in this theory that allowed the pain processes not to be inhibited and to go directly to the cortex of the brain, where perception would occur, And so these are some of the theories of what was thought to be reflex sympathetic dystrophy. Now, again, historically, there was thought to be 3 stages of reflex sympathetic dystrophy. This is important because you still read about it in some articles. One stage was the acute denervation stage. So after the acute injury, patients would develop this denervation, and it was thought that that acute denervation produced the sensitivity and the pain. And then the second stage, and this would last from about 3 months or so to about 6 months. The dystrophic or hypersensitivity stage was the next stage, and that was thought to occur from about 6 months to a couple of years, where the extremity wasted and you had the demineralization of the bone, and it was not being used by patients because of the pain, and there was a hypersensitivity of the extremity. You touch the arm and they jump and they'd scream and tell you how painful it was to just light touch. And then the final stage was said to be atrophic stage. The atrophic stage is a wasting away of the extremity. Muscle loss, disuse, osteoporosis, and essentially a completely dysfunctional extremity. So these are historically the 3 stages that were said to occur in reflex sympathetic dystrophy. However, on looking at this in patients, it was observed that this didn't always occur. That there were patients who did not always get dystrophy or atrophy, but continued with pain, and that the stages that patients, except for the atrophic stage, patients could move back and forth between these 2 stages. They may have acute denervation, they may go into a hypersensitivity dystrophic, but then they may reverse and then go back and decrease the dystrophy and the hypersensitivity and get some functioning back. So it wasn't absolutely correct that patients automatically went from stage 1 to stage 2 to stage 3. And so these, this staging of sympathetic dystrophy is pretty much thrown out, at least by pain physicians. You'll read in the orthopedic literature, sometimes the neurological literature of these stages, but just realize that it's not felt to be correct. That the presentation is a spectrum, and this spectrum can move from one stage or one part to another, and one stage can last for a long time or a short time. For example, I've seen patients who have had an injury and they progress rapidly within a matter of weeks from the injury stage to a atrophic stage, very, very rapidly. So it wasn't, these stages really didn't describe it accurately. Okay, so 1994, the definition of complex regional pain syndrome was introduced. And it was described as here, a painful syndrome, regional pain, sensory changes, for example, allodynia, abnormalities of temperature, pseudomotor activity, swelling, skin color that occur after a noxious event as trauma. And it's a regional syndrome, complex regional pain syndrome, regional syndrome, unclear pathophysiology, affecting usually an extremity, hand or foot, but it could occur in any other part of the body. So this was the new definition applied to what was termed reflex sympathetic dystrophy in the past. And they realized at that meeting, like I said, there were 2 types of sympathetic dystrophy, reflex sympathetic dystrophy and causalgia. So they said it's going to take time to get people used to this new concept, and so we're going to have a transition phase. And the transition phase was to define CRPS 1, type 1, and CRPS type 2. And in CRPS type 1, these are the features, and this is what was described under each of these categories. So as a couple examples, in terms of etiology, for example, CRPS type 1 could be any lesion. Somebody could get a paper cut, somebody could bump their hand, whereas in CRPS type 2, or causalgia, you had to have a nerve lesion. A nerve had to be damaged. It had to be clear that there was an injury to a nerve. And then we can go, this will be available to you to review. You can go through each of these and you can see what the differences are in this categorization of CRPS 1 and CRPS 2. And the reason I'm not going to spend a lot of time on it is because, as I said, the plan was that this would be a transitioning step to get people to used to the concept of complex regional pain syndrome and applying it to RSD and to causalgia. And then the idea was that eventually everything would be under the umbrella of complex regional pain syndrome. And these are just continued more features and what was described to occur in CRPS 1 and CRPS 2. And then they said, well, how do you make a diagnosis? This comes from the 1994 description. And so what they said was, okay, you got to make, how do you determine CRPS 1, reflex sympathetic dystrophy, CRPS 2, causalgia? So for RSD, you needed to have the immobilization, and you had to have all four, from numbers 2, 3, and 4, had to be present for RSD. And all of these criteria had to be present for causalgia. I'm not going to read the criteria. You can read it on the, in the slides that'll be available to you. But the concept is what I want to get across, that there were different definitions for CRPS type 1, making a diagnosis, and CRPS type 2. And then some people in the pain community said, well, that's all well and good, and it's good to move along in the diagnosis and definition and so forth. But people criticized the IASP definitions and criteria. And so this was one of the first criticisms of that. And this individual said that, well, the key clinical symptoms should be all of these that's listed here. Again, I'm not going to read them for you. These you can read in the slides. But the point is that after the 94 meeting and the publication of these criteria, there were individuals who said, well, what you did is good, but it really doesn't match what's going on clinically, and this might be better. Okay, so also, what was described by IASP and by Janik in '96 were clinical criteria. And researchers said, well, we need something more specific to put in for research, for patients to enter research. And so this was a modification of the IASP criteria for research diagnostic criteria for CRPS. Again, I'm not going to read all of these, but all of these things had to be present in order for the diagnosis of CRPS. And notice you don't have CRPS 1 or CRPS 2 here. You just have CRPS. For all of anything in CRPS for research purposes to be made. Now, so now in the most recent thing, It's from, I think, the National Consensus Group that looks at and defines clinical problems and treatments and so forth. So this is February 2011. So they still have a clinical diagnostic criteria, and what did I do? Let me start again. And they have a research diagnostic criteria. And the difference is really, if you look at it, that in the clinical criteria, one symptom in 3 or 4 of the following categories must be present, from one of the sensory, one of the vasomotor, pseudomotor edema, motor trophic. You have to have 3 out of 4 of these findings for clinical diagnosis, and in research you have to have all of them. So that's really the big difference between clinical and diagnostic criteria for CRPS. You need to be aware of the differences in the diagnoses, clinical and research. They're essentially the same except for the criteria for all of these to be present in research and 3 of the 4 present in clinical. Again, you can read the specific things in terms of what's listed under here in the slides. Now, what about epidemiology and demographics of CRPS? The mean age is the mid-30s to the mid-40s, predominantly females. It predominantly affects the upper extremity, and the types of injury and the percentages reported of the injuries that lead to it are over here. So fractures and sprains are by and large the greatest trigger for developing CRPS, and then these others decrease in this order. Okay? Now, symptom frequency. Now this is important because while originally the definition called for burning pain, but only about 80% of patients have burning pain. They may report pain of some other quality, some other characteristic. 20% will report just an aching, a pain they can't describe. It doesn't necessarily have to be burning pain. And if you go down the list of the symptoms that occur and the signs that occur, you can see that not all the patients have all of the changes. It's not 100% have to have every change. And that's why those criteria say, you have to have it's like a Chinese menu. You pick one out of this column, one out of that column. You have to have all of those. You have to meet certain ones out of each of the criteria, but they don't have to have all of the criteria. And this comes from British Journal of Anesthesia review article on the presentation of these symptoms. So that's important to know. So if a patient comes in and they don't have color changes, but they may have some swelling, or they may not, and they don't have burning pain, but they have a nondescript aching, they can't quite describe what it is. So you have to have a high level of suspicion that it might be a CRPS, and you diagnose this by exclusion. You find if there's anything else that can explain it, and if there's nothing else to explain it, then, and you have these other features that we mentioned, it could fall into this category of CRPS. Sign and test frequency. Again, when you look for signs and you test for some of these signs that are listed here, you may not find 100%. You won't find 100%. Some patients will have it, not even allodynia. Not every patient will have allodynia. And not every patient will have color changes or temperature asymmetry or decreased range of motion. A large percentage will, but not everyone. So you have to just keep that in mind in terms of having a high index of suspicion for the condition and realizing that not everyone presents with every manifestation 100% of the time. Now, one of the things that we look for in CRPS is if there's a temperature difference between symmetrical points on an extremity. So in order to look for a temperature difference, we have to have an idea of what is normal and what's abnormal. So this is one measurement of part of the body that was done using infrared measurements. And what they did was take normal people without any complaints, any problems, and they would do infrared scanning. And they would measure the temperature on symmetric parts of the body and see what the difference was. So if you look at these areas, scapula, triceps, biceps, etc., this was the 2+ standard range of deviation was anywhere from 0.5 to 1 degree Celsius. And if you had this amount of difference, it was 2 standard deviations from the mean. So this is how an abnormality in temperature is defined, by taking all normals, studying them, seeing what the mean is, seeing what the standard deviation is, and anything that falls outside of that standard deviation, 2 standard deviations, would be abnormal. So if you're measuring, like for example, fingers or the palm of a hand, and you measure the temperature, then from one side to the other, you can have up to 1 degree Celsius difference, and it still could be normal. So therefore, if you look for temperature differences, you really have to measure temperature differences with a thermistor. If you try to feel with your hands, it's not sensitive enough. It's been shown that if you try to tell temperature differences from one object to the other, you have to have up to like a 2 to 3 degree difference, Celsius difference, in order to determine a difference. And if you go by touch, you may miss a lot of people who have a significant difference in their temperature between symmetric points, and you'll write them off as, oh, it feels normal, so they're normal. You really have to measure the temperature and record it and write it down to know whether or not it's abnormal or not. Okay. This, I show you an example of a patient from many years ago that I saw. This was a woman who was driving in a car, and she was rear-ended, and when she was rear-ended, her hand came off the steering wheel in the jolt, and it hit the dashboard. And she, very shortly, within a day or 2 at the most, developed swelling of the extremity. And you can see this was a couple years after the event. I saw her a couple years afterwards. But you can see the swelling. You can see the redness in the joints. You can see dystrophic changes occurring. And you can't see the nails so well, but there were some nail changes. And here, hopefully you can make out, she wore an elastic bandage to help keep the swelling down. And here's the marks from the bandage, okay? And this was after it was off and for a while, and the imprints remained in place for some time. Notice the redness, notice the swelling. The fingers are fixed. You can see some atrophy in here. So this lady had complex regional pain syndrome, upper extremity. It was thought on one x-ray that she had a hairline fracture of one of her metacarpal bones. But on subsequent x-ray or review of the x-ray, it wasn't quite clear. Not everyone agreed on that. Okay, so this, just wanted to show you this as an example. And this lady didn't go through stages. She went immediately from trauma to swelling to dystrophy and some evidence of atrophy in some of parts of her extremity, all within a matter of days to a couple of weeks. Okay, let's look at pediatrics. CRPS does occur in the pediatric patient. This is important for you to know. And what's the difference between children and adults? Well, in children, most of them get it in their lower extremity, whereas in adults, it's more in the upper extremity. And spontaneous pain is common, and most have some mechanical allodynia. And sex ratio is mostly female. In adults, I showed you that it was mostly female, although there are some reports that say it's equal. Psychological aspects are not well documented in children, but depression and marked psychological changes occur in adults with CRPS. And it used to be thought that the psychological changes were creating the symptomatology, but it has been agreed upon that the CRPS produces the depression. And the reason for that is those patients who are depressed with CRPS, if you get their pain under control and their function back, their depression gets resolved very quickly. So it's not believed that depression per se causes the CRPS, but that the CRPS causes the depression. In, again, in children versus adults, triple phase bone scan gives mixed reports. Don't forget, in children, your bone is developing and your caps epiphyseal plates are not fully formed. And in adults, you generally have increased uptake in the affected part. Now, the treatment includes multimodality in adults. Traditionally has been sympathetic blocks, but we use a multimodality approach. Now in children, how are you going to get them to hold still for a needle? And the only way you could do that is with general anesthesia. If you try to do it with heavy sedation, you stick them and they jump all over. You know, it's, they're quiet up to a point, and then you go to put the needle in and they're jumping all over. So if what is generally done in children is physical therapy, TENS unit, cognitive behavioral therapy where possible. If you need to do sympathetic blocks, it is recommended and believed to be best to put a catheter under general anesthesia, secure the catheter, and then run an infusion continuously for a few days of local anesthetic to block your sympathetic nerves, rather than doing it by intermittent blocks. The timing of treatment. The duration of the disease does not affect treatment outcome in children. There's mixed recommendations saying the earlier you get it in adults, the better off your results will be. And again, technique for block, continuous infusion versus single shot. Also in children, there seems to be a phenomenon where the children, if you will, outgrow the CRPS. So I've seen a couple of teenagers, 13, 14, who have a presentation of CRPS and were treated, and when they went from their teenage years into their adult years, 18 to 20, 21, their symptoms resolved. So it could be a matter of time, and many of them will just have resolution. Whether it's hormonal or exactly what, I don't know, but that's been an observation as well. So what is CRPS? CRPS is believed to be a neuropathic pain syndrome. And if you look at sympathetically maintained pain, sympathetically maintained pain can affect many neuropathic pain conditions, from neuropathies and neuralgias, phantom pain, herpes zoster. There are reports in the pain literature of all of these conditions responding to sympathetically maintained pain. To responding to sympathetic nerve blocks. And so all of these conditions have some degree of sympathetically maintained pain. Not all of them respond. So it is probably on the continuum of a neuropathic pain condition. Now, what about, the patient I showed you with the edema and patients with swelling? I remember there was a young girl, 16 or 17, 18-year-old, who had a disposable flash camera. It was several years ago, and had taken a picture, and the flash bulb exploded and it burned her finger, and she developed massive swelling, discoloration, allodynia of that entire extremity. She had been seen by another pain doctor and had sympathetic blocks. With the sympathetic blocks, the swelling, the pain, the discoloration, everything resolved for about a day or so. So it was recommended that she go and have a sympathectomy. But the mother was reluctant to have a sympathectomy because she was concerned about, surgery and would it work or not, and so she was looking for another opinion. And what happens? Why does a complex regional pain syndrome that produces edema respond to a sympathetic block? This is one theory where you have the noxious event that produces the sympathetic activity in the spinal cord, and then you have the efferent nerves going out to the sympathetic ganglia, and the sympathetic discharge in the venules cause constriction of your postcapillary muscles in the venules, causing swelling proximal to that, leads to leakage of fluid from the vessel, leads to edema. This gives rise to interstitial pressure and substances that increase nociceptive excitation and firing of nociceptors. And then the afferent input from this goes back into the spinal cord, and so this is the concept of the vicious cycle or vicious circle of events. And if you block your sympathetics and you stop this process, then you allow for drainage. You open up these venules, allow for drainage, and the edema resolves. So that's a theory. I present it as a theory as to how do sympathetic blocks help to resolve swelling and discoloration of a individual with CRPS. Again, the circle of vicious circle of responses and reflexes. So you have a trigger pain, a fracture, afferent input causes excitation within the central nervous system and then produces afferent barrage of excitation to vascular structures, here vascular structures, muscle spasm, and to sweat glands. And so this is what is thought to be the initiating event in the circle of reflexes. And then within the nervous system, probably through nitric oxide and other mediators that are released, spread in the cord, and involve other areas. So you end up getting a non-dermatomal distribution of involvement. It's not just it's in a wide area and it's non-dermatomal. And with more area involved, you get more efferent barrages of excitation and more stimulation and changes that cause afferent barrage of information that keeps the thing going. And so, again, a theory is you do a sympathetic block, you break the cycle, the nervous system is allowed to reset itself, if you will, and the patient does pretty well for at least for a period of time. Okay. Now, just go sympathetic component of pain, response to sympathetic blocks, sympathetically independent pain, and sympathetically dependent pain, sympathetically maintained pain over here. So this patient who has a sympathetic block may not respond and have more of sympathetic pain and would be in this category. And those who have sympathetically maintained pain, patient B, would respond and be more in this category. Now, the other thing to realize is that patients can move back and forth between sympathetically maintained and sympathetically independent pain. You can do sympathetic blocks on some patients, and they do pretty well, and they come back, they get another block, but then the blocks don't work. And you do the same block, and you don't understand it, and must be technical, and you repeat it, and the block doesn't work. So you have to, the reason why, don't know, but realize that patients can move back and forth between independent and maintained pain. All right, other concepts of the pathophysiology: neurogenic inflammation, immunological mechanisms. These are thought to be processes that produce the phenomenon complex regional pain syndrome. Now, I just want to go over in the couple minutes left, because most of you like to know about nerve blocks. And so let's just talk about the sympathetic nervous system and doing sympathectomies. The sympathetic nervous system is organized. The sympathetic nervous system, where does it originate? What levels? To what? Anyone? Thoracic what? Where does it start? T1, down, and how low does it go? Anybody? To L2, your preganglionic sympathetic neuron that originates from the spinal cord, T1 down to about L2. So it's organized. Your T1 to T4, maybe T5, is organized in what's called the cervicothoracic sympathetic outflow that gives you the afferent input to the head and neck and the upper extremities. It also gives you outflow to the heart and some of the thoracic cavity. And so doing a stellate block, you can get the sympathetic efferents and afferents. There's thought to be afferent input, painful afferent input through the sympathetic nervous system. You can get the sympathetic distribution, let's say, to the head and neck, upper extremity, and to much of the thoracic cavity through a stellate block. In the from T6, T5-6, down to about T12-L1, you have your splanchnic outflow. And your splanchnic outflow, you have your greater, lesser, and least splanchnic nerves that originate, and these nerves innervate the abdomen. They innervate from approximately the stomach to the transverse colon. And when you have a patient with abdominal pain, say from pancreatic cancer, and you do a celiac block, you're blocking the sympathetic efferents and afferents from the abdomen to and from the abdomen from the spinal cord. So a celiac block can be done with a single needle because all the nerves pass through, first form one of the splanchnic nerves, then they pass through, and then they intertwine to form the plexus, and there's also the celiac ganglion that is present within the abdomen as well. So what's the difference between a plexus and a ganglion? This is a board question. Board question. The difference between a plexus and a ganglion is what? And they give you a list to choose from. Anybody? Nobody? Okay, look it up. You guys should look it up. I'm not going to tell you what it is because that's something you should know that's been asked on the boards. So now you get the stomach and the abdominal contents from the stomach through the transverse colon by doing a celiac block. Lower extremities, the lumbar sympathetic block, the lower extremities are supplied by around T11, 12 or so to L2. And so you can get that outflow by doing lumbar sympathetic blocks. More recently, in the last couple decades, there's been the hypogastric plexus and the ganglion impar, and that originates from L12, maybe T12 origin, and you can do a hypogastric plexus block for pelvic visceral pain and ganglion impar for pelvic pain as well to see if it's sympathetically maintained. So the sympathetic nervous system is isolated, broken up, organized, as however you want to look at it, into these different areas, and it allows us to put a needle at a specific location to inject our drug and to block the sympathetics to that region of the body and obtain a sympathetic block. I'm not going to go through all of this and the pathophysiology with plasticity of nervous system changes. I just want to talk to you about therapy. Therapy is complicated and complex, as the name complex regional pain syndrome. It is multimodal, polypharmacy. It requires many disciplines from a pain physician, interventionalist, rehab physician, psychologist to help the patient get through their problem and to rehabilitate. This, I'm not going to go through this scheme, it's on the slide, but it shows you a guideline of how to begin with rehabilitation processes, psychological approaches, interventional pain approaches, and how these intertwine, and if the patient has a response or no response. So take a look at this. This is an entire lecture in and of itself, and it's on the slide for you to review. Okay? What do we know from evidence-based medicine in terms of treatment medically? It should be our corticosteroid tapering dose can be effective in attenuating or reducing the symptoms of the pain or pain flare. Calcitonin doesn't work. It's been tried, it's been studied, it doesn't work. Vitamin C has been reported in double-blind studies to be preemptive in preventing RSD in patients who have a Colles fracture. Patients treated with vitamin C at the time of treatment of their Colles fracture and for a couple of months after had a lower incidence of developing complex regional pain syndrome compared to those who got placebo. Bisphosphonates, primarily IV pamidronate, has been documented to attenuate the severity of pain in complex regional pain syndrome. Its length of effect is variable. It can be anywhere from days to weeks to a couple of months. Okay. Biofeedback, relaxation, that is supposed to turn off your sympathetics. So if you get someone to do biofeedback and relaxation and you put a temperature probe on their finger and they watch their temperature and they learn to raise their temperature, the only way they can raise their temperature is blocking their sympathetic outflow to vasodilate. So that's where biofeedback may come in. Acupuncture has been used in treating it. I don't know what the success rate is. But again, for nerve blocks. Stellate block. Oh, wait a minute. So the patient lays supine. Remember the organization of the sympathetic system that I showed you a couple slides ago? Patient lays supine with a pillow under the neck so their head is extended. And you look at the landmarks, you see the sternocleidomastoid, the sternal head of the sternocleidomastoid. You have your trachea here. You have your sternal notch. And at about the level of the cricoid cartilage, anatomically, that's approximately C6 cervical level. So needles placed perpendicular to the neck until it gets down onto the transverse process, at which time local anesthetic is injected, and then the patient is put erect or head up, and that is to allow some gravity effect for the solution to go down to the upper thoracic nerves. And you look clinically, clinically you look for Horner's. I think you can appreciate the ptosis. It's a little hard to see the meiosis, and there's a suggestion of redness of the eye or conjunctival redness on the side of the block. That's from the sympathetic block. And temperature-wise, you measure the temperature, and you would like to see, if, depending on where you start, of course, you'd like to see about a 3-degree rise in temperature Celsius.
Is there a cardiac effect where you see a rise in temperature and a rise in the pulse?
You don't, but interestingly, sympathetic blocks have been used in patients with angina, but with mixed results. It is interesting that in response to your question, and kind of related to this, spinal cord stimulator treatment has been shown to be efficacious for complex regional pain syndrome, but it lasts maybe about 3 years and it starts to wane. Unstable angina, not controlled medically, has been treated with neuraxial spinal cord stimulation as well. So it's interesting that the spinal cord stimulation may turn off your afferent input from your cardiacs. From your cardiac afferents and efferents. But in terms of practically, clinically, if you're doing the right side, then you would expect a rate effect, because the sympathetics on the right side innervate primarily your SA and ventricular nodes. If you're doing the left side, you would expect a contractility effect, because the sympathetics innervate primarily the left side of the heart. But in practice, clinically, it's not significant. Okay. Lumbar sympathetic block, and we'll close it up shortly. needle, here's a sympathetic ganglia in the lumbar region. Sympathetic ganglia is located in the anterolateral aspect of the vertebra. It's in a fascial plane that is away from your somatic nerves. So by placing a needle near the sympathetic fascial plane where these nerves are located, you inject your local and it stays in this fascial plane and it gets the sympathetics only, and you can inject dye to verify it, especially if you're doing a neurolytic procedure. You inject dye to make sure you don't get spread of dye going back to the somatic roots. So this is a patient in the lateral position, needle going in, and the needle being placed in the anterolateral aspect of the vertebral body near the sympathetic chain. Here's one here, here's here. And so your needle goes right here. You give the local, and here's another picture of it, cross-section, where the needle is placed right in here, away from the somatic nerves. And you can either put one needle and give a large volume to get spread up and down the fascial plane, or you can put in multiple needles at the various levels. Single needle is more comfortable for a patient, it's less painful, and if you can do that and get your block, patients will likely come back more than they would if you had put in 4 or 5 needles because it's painful. Here's fluoro view. So the needles are on the anterolateral aspect here. You can see them here. Here, it's a little hard to see the vertebral body, but here's the vertebral body, anterolateral aspect, just under the facet, just lateral to the facet joint, and that's what you would look for fluoroscopically. Here you inject dye, and you see the spread of dye in the vertebra. You see the spread of dye, I'm sorry, in front of the vertebra.